As an introduction, Roshni ma'am, you all may familiar with Roshni ma'am, who is a professor and head of Department of Commerce Department, Government Ayurveda College, Thiruvananthapuram. She had completed her BMS from Government Ayurveda College, Thiruvananthapuram itself, and her first PG in Samhita and Siddhanta in 2002, and second PG in Kaumarapatya in 2009. Also, she had done her PhD from Kerala University in childhood autism in 2020. She's a recipient of Best Dr. Atreya Award in 2019 by Government of Kerala for her contribution in field of Ayurvedic pediatrics. Also, she was the Best Project Coordinator in 2019 by the Government of Kerala for the activities in connection with Snehadara project and Ayurvedic management of development with disabilities in children. We are so honored to have you here, ma'am. I welcome you to the session. Please, ma'am.
Thank you. Am I supposed to start now? I think the participant number is only 25.
Yes, ma'am. Others will join, and we will be providing recordings also. So most of them will be join later, or they may look to us recording classes.
Is it? As per our talk, you told it will be more than 100. That's why I was curious.
Yes, ma'am. Previously, we thought that it will be around 100 people, but most of them were busy with some other work, so they will look towards recorded classes.
So if so, we can shift to another day. And among the 25, it's one is me and other 2 or 3 are you to organize us now. So it's WhatsApp number is only less than 20.
But all the participants are almost everyone is Kaumarapatya graduates, and all are eagerly waiting for your class now. Ma'am, shall we?
They are Kaumara graduates, Kaumara postgraduates.
Postgraduates.
How many are there of completing Kaumara PG?
I think majority are Kaumarapatya because we have circulated all around the India. So a lot of people are from northern part of India now.
Can they raise their hands if they have completed the Kaumara PG so that they can shift the standard of the paper like and otherwise it will be in the UG clinician standard. Can the participants raise their hands if they have completed a Kaumara PG? Anyone? Then there is no need to surf on to the basics.
Yes, ma'am.
Only one sir is there. No, Dr. Tinku is there. Then who else?
Madam Jidesh.
Hello, Jitesh.
Yes, madam.
വേറെ ആരെങ്കിലും ഉണ്ടോ കൗമാരംകാര്? മീര?
Miss A.
Hello.
Hi, ma'am.
These are my students. No need to actually teach in detail for them. So if it's a platform for Kaumara PD, shall I skip the basics?
Ma'am, some graduates are also there. Like not everyone is postgraduate.
Is my slide visible?
Yes, ma'am.
It's in the full screen.
No, ma'am. Can you maximize it?
Now
No,
is
it
it okay?
Yes, ma'am.
So directly into the topic, management of childhood epilepsy. Like a seizure or a convulsion, which is which comes very often in pediatric practice, has to be. Am I audible?
Yes, ma'am.
Seizure or convulsions, which is a which usually comes to you in a general practice, and its prevalence is almost 10% in pediatric age group. So first, our duty is to differentiate whether it's a seizure or an epilepsy. Usually, seizure is a symptom, while epilepsy is always a disease. Seizure is usually a motor activity, usually a convulsive attack. And while epilepsy need not be every time convulsive, epilepsy can be otherwise as well. Usually, the word seizure means something it's shaking. And it can be a presentation of some abnormalities other than the brain. Like if the baby is having a high fever, hyperpyrexia, the baby can have seizure. That we call it as febrile seizures. Also, if the baby is suffering from sepsis or any other infections which has reached crossed a particular level, it can also cause a seizure. Again, hypoglycemia, the sugar levels are coming down. It can precipitate as a seizure. So hypocalcemia. So hypoglycemic seizure is very common in newborns, especially when a pregnant lady who is suffering from gestational diabetes is giving birth to a baby. So the chance of that baby to have hypoglycemic seizure is very common. But don't think that it's an epilepsy. It's just a seizure because of that lowering blood sugar. Again, hypocalcemic seizure, or you can even call it as a TED-10, is also common. Again, a sudden head trauma or head shake can cause a seizure. Hypoxia is notorious to precipitate a seizure. Again, toxins, cardiac arrhythmias, everything can cause seizure. So, if a baby is having a convulsive attack, don't come into a conclusion that he is having a brain insult. It can be something in the electrolyte imbalance. It can be even a fever or some extra cranial pathologies. So to differentiate between this, seizure and epilepsy is a disease concerned especially with the neurological, concerned with the brain itself. So for a seizure to manifest, we need actually a precipitating cause, mandatory. usually an fever or an electrolyte imbalance or something abnormal suddenly happening in the brain can precipitate a seizure. But for an epilepsy to manifest, that precipitating cause need not be that evident. It can be an unprovoked seizure. That unprovoked is very important. Even without any provocation, seizure can manifest. So, epilepsy can be defined as 2 or more unprovoked seizures occurring in different time, like at least 1 day apart. One unprovoked seizure is happening this week and another one on the next week. Parents are not aware what triggered that seizure. So that can be under the suspicion of epilepsy. Am I audible?
Yes, ma'am.
Okay. So we are directly going into the epilepsy because seizure is just a clinical sign. So it need to be manifested it need to be managed in the systemic level. So if it's a hypoglycemia which is precipitating a seizure, so being a clinician, our duty is to correct that blood sugar level. If hypocalcemia is precipitating, then our duty is to correct that calcium level. If fever is precipitating a seizure, our duty is to control that fever. Actually, to underline, our duty is not to control the seizure attack. Just treat the cause behind. So it's not that level when it comes to epilepsy. Epilepsy is actually a disease pertaining to the brain. Actually, it's a different shift from the normal balance of excitatory neurons and inhibitory neurons in the brain. As you are all familiar with the excitatory neurons and inhibitory neurons in the brain, and they maintain usually a very homogenic balance so that we don't have any seizure attack. But this balance is disrupted in many of the brain diseases, especially in metabolic deposits of the brain infections like meningitis, encephalitis, or any disease which affects the brain. This balance is distorted, and this is the root cause of epilepsy. But apart from that, some other causes also play a role in the manifestation. For example, age. The childhood age is more prone to have seizure attack. That's why 10% is suffering from such diseases. Because the threshold of the brain to counteract or suppress a seizure is very low in the pediatric age group. So with a minor cause itself, pediatric population can have the chance to have a seizure or an epilepsy. And also the Spaitika Prakriti kids. Because of their genetic profile, they also have a more tendency to have a seizure. And certain genetic composition also, genetic abnormalities like Down syndrome and all, they do have a tendency to have a seizure with a minor reason itself. So something other than the brain pathology is having a definite role in the manifestation of epilepsy and the seizure. So this endogenous factor means which is innate to our body. That's the age. If with the same cause, same brain abnormality, if the child grows up, if the brain abnormality is lying over there unmanaged, but when the child grows up, the tendency to have an epilepsy is less. That is, the threshold against that epilepsy is increasing by age. Similarly, if baby is having Spaitika Prakriti is more prone to have seizure. So if we manage that excess pitta also, that tendency is reduced. Then comes the epileptogenic factor. That's a real villain behind. That's a real factor behind. Infections, head trauma are all notorious to cause or form this epilepsy. And one more factor is the precipitating factor. Even though, as I told earlier, it's an unprovoked, epilepsy is always an unprovoked attack. But for certain, it's underlying certain precipitating factors are there, though not that evident like in a seizure attack. Certain precipitating factors are there. That is sleep deprivation. If the baby didn't have a good sleep last night, the chances to get that seizure attack or epilepsy is more. Again, the stress, mental stress, unventilated mental stress is notorious to precipitate an attack. Again, the hormones. Many cases are being reported in the OPD that girls who are nearing their menarche or had just their menarche are having an epileptic attack. They didn't have a history of such attacks in the prior stage, but that hormonal imbalance, especially during that menarche, is precipitating an attack. And during every menstrual cycle, they are having an attack of epilepsy. And this group of epilepsy is called catamenial seizures. Catamenial means those which get triggered with these hormonal variations. These are the underlying precipitating factors. These are not only the only alone precipitating factors like traveling for a long distance, especially with the wind blowing on the face, is another precipitating factor. Bright light is a precipitating factor. So usually this epilepsy is an interplay between all these three factors. The most prominent factor is the epileptogenic factor, but this age, genetic profile, prakriti, etc. have a definite role, which is the endogenous factor, and also this precipitating factor has a role in precipitating the attack. As this disease is having a Vegavastha and Avegavastha, this Vegavastha is pushed or contributed or precipitated by these precipitating factors. So our duty being a physician is to address all these factors simultaneously. Even though our target of management is epileptogenic factor or the pathology in the brain, but we should give more importance to precipitating factors because this precipitating factors is usually related with the Rasadadu or Rasadadu Dushti. So without addressing the precipitating factors, we can't proceed to address the epileptogenic factor. So all these factors should be given due consideration in the management of epilepsy. Coming to febrile seizures. Because it's not a part of epilepsy, I know, but it's a common manifestation in pediatric age group. So febrile seizure. Usually it comes without a CNS infection. Happens in hyperpyrexia. Hyperpyrexia means the temperature exceeds 103 or 104. When the baby is under the age of 5 years, the hypothalamus, who is a main temperature control organ, is a controller behind. Actually, under the age of 5 years, hypothalamus is not that mature to have a control over the core temperature. So when the baby is having fever, the core temperature rises uncontrolled, and this hypothalamus is not that mature to evenly distribute the temperature to the extremities. That is why Acharya Kashyapa has narrated that when a child is having fever, it's leladasya atitaptada and padayo shaitya, which doesn't happen in an adult. When we have fever, we have hot extremities and our scalp temperature also will be hot, and the same temperature will be felt on the extremities. But in pediatric age group, especially under the age of 5 and more in neonates, the core temperature will be rising. So if you feel that mouth, inner surface of mouth, inner oral cavity, it will be too hot, and even the scalp will be too hot. But when you feel the extremities, it will be cold. Padayo shaitya. That's the inability of hypothalamus to distribute the temperature evenly. So what happens? The core temperature goes on rising, and the tendency to of this temperature to affect the brain function is more. So when the temperature reaches a hyperpyrexic stage, brain seeks the help of, actually it's a defense mechanism of brain and seeks the help of musculoskeletal system, and the brain orders the muscle to have a violent contraction so that muscular contraction will be having a vasodilatation and the temperature, and the baby will be sweating profusely and the temperature will be controlled. And even without sweating, that when the muscles are being contracted and relaxed, the body temperature will be dissipated, and it is a trick of the brain to control the temperature. So it's a defensive mechanism of a healthy brain. So when the baby is under 5 years, having a hyperpyrexia, when the core temperature rises, there's a convulsive attack. Make sure that it's a convulsive attack and the duration is within a period of 5 to 10 minutes. And after the convulsive attack, the body temperature will come down and no residual damage will be there. The seizure will be controlled by its own within the duration and the baby will be healthy and running around. So this is a typical feature of febrile seizure, and it's, as I said earlier, it's a reflection of a healthy brain. So no need of any anti-epileptic medicines here. Our effort should be only to control the temperature, helping the body to control the temperature, which can easily done by sponging or even talam and labum on this lalada can do wonderful results. Any pitta shamana churna like chandana or amlaki churna or even sudarshana churna can do wonders. No need to give an internal medicine over that time. So external sponging or talam will help a lot in controlling the temperature. Another type is like this I was speaking about typical febrile seizure. Another is like atypical febrile seizure. Atypical febrile means it's not a typical one. A bit deviation from the normalcy is there. So the attack may not be mandatory a hyperpyrexia. It can be a temperature just above 100. Even with the temperature above 100, baby will be throwing seizures. And it need not be essentially convulsive. It can be a twitching of the face muscles or uprolling of eyes or anything like that. It may last long, more than 10-15 minutes, or it can go up to status epilepticus. And after that seizure attack, the temperature is not getting controlled. It's actually shooting up. So this is not a healthy, not a reflection of a healthy brain. So it's something abnormal and we call it as atypical febrile seizure, deviating from the typical pattern, which is pointing towards an abnormality or pathology in the brain. So this usually happens in kids with brain abnormalities, usually in kids with autism spectrum disorder, kids with cerebral palsies, kids with hypoxic ischemic encephalopathies, kids with other brain pathologies, genetic abnormalities and all. This atypical febrile seizure is happening. So even with a mild increase in temperature, baby is having seizures. So this need to be managed in a different way. So even though we need to assist the baby in controlling the temperature, and after that we need to target at that brain pathology also. So coming to classification of seizures, upon the presentation of the seizure, we usually classify it as focal, generalized, and epileptic syndromes. Focal means only a part of the body or a part of the brain is involved. And we can either call it as focal or partial seizures. And the second category is the entire brain is having an abnormal electrical discharge. We call it as generalized seizures. And third comes an epileptic syndromes, which we won't be dealing in this class. We'll be speaking about focal and generalized seizures. Focal generalized was the older classification, and the latest ILAE classification ILE means International League Against Epilepsy. That's that international association which is controlling the rules and regulations regarding that epilepsy classification, management and all. So it's that international standard classification which we have to follow. So according to the latest classification, they have redesignated a name of partial seizure for instead of focal seizures. It's actually one and the same. Instead of the focal term, they have used partial. Again, that is denoting only a part of the brain or the part of the body is involved. So the first category is simple partial. Simple partial means the baby is very much conscious. He or she will be knowing that I am having a seizure attack. And he will be able to detail that to the parent that, Mama, see, I am having a seizure attack, something abnormal is going on. That much that baby will be conscious. That is very simple. Simple and only part of the body is involved. It can be a motor, it can be sensory and also autonomic. Motor in the sense it's usually a convulsion, or sensory means usually any of the senses will be involved. It may be usually an abnormal feeling of smell. The child will be narrating, Dr. Auntie, I am having a typical smell sometimes. It's maybe like a rotten egg smell or a flowery smell. See, now I am having a smell now, I am sensing it. And after a few minutes, it's getting faded. Even it can be visual sensory as well. It's a narrated meaning they are seeing an aura around the head, a bright aura, as if like in the God's picture, we can see an aura around the head of the Buddha. And similarly, they see a lighted projection around that body when they see. So it can be visual sensory, blazing lights like this going in and out. So any sensory abnormality can happen with this simple partial. Can be auditory sensory, like buzzing sound, like the sound of a motorbike accelerating, and an om chanting sound, like resonant sound can be there. Different sensory abnormalities seizure is also there. Usually, it is sad to say that many of the sensory seizures are not appreciated by the doctors as seizures. They are usually appreciated by the parents and doctors as a part of psychological abnormality or even psychiatric abnormalities. So we need to know that many sensory abnormalities are associated with seizures and also autonomic seizures. Autonomic seizures means autonomic nervous system will be deranged for a bit time. The child will be nervous, feeling nervous, uncontrolled passage of usually the bladder. Baby will be blushing off, and the sudden urine passage will be there. Baby will be conscious but uncontrolled. Urine and bowel can be there. That sudden sweating, loss of bladder control, blushing and all comes as autonomic seizure. That is to speak about simple partial. Then comes the complex partial. Complex partial is a bit more severe. Here the consciousness is a bit impaired. It's not fully lost, but it's a bit impaired. Actually, it is a bit more higher than the simple partial. The abnormal electrical discharges are not spreading through the entire brain, but it's actually spreading. Consciousness is impaired. And one more category is the partial seizure evolving to secondary generalized. Actually, the seizure starts as a simple partial and then it's having a tendency to get generalized. Then I think I'll show the videos of simple focal seizures. This is a child with simple focal seizure. Baby is very conscious. Suddenly the hands started shaking. A typical movement is happening. Baby is looking at the hand. He is totally aware. But the writhing hand movements are there. A simple partial. That much simple it is. will be conscious, perfectly conscious and aware of that seizure attack. See another simple partial. See, again that head movements was there. Eye movements was there. Baby was conscious. Now coming to complex partial. Complex partial seizure. Here consciousness is a bit more deranged. The same child. And apart from the eye movements, other body movements also will be involved. See, the respiratory arrest is happening during this time. Baby is getting unconscious. Another is secondary generalization. Secondary generalization means it's not that important if it's not from a Kaumara fraternity. Secondary generalization means like it starts as a simple partial. It starts with one part of the body and gets generalized to the entire body. And then coming to generalized seizures. Generalized seizures is actually spreads, the electrical activity spreads entirely through the full brain, and actually the baby will be completely unconscious. And even the post-ictal seizure also period also will be there. Like baby won't directly regain the consciousness after the seizure attack. He'll be too drowsy and will be having a post-seizure drowsiness. So regarding that generalized seizures, absent seizure is the main one. Absent seizure is like it's a typical absence of a period of unconsciousness which is usually found in kids. See, the child is having an absent attack. Into consciousness. Another type of generalized is atonic seizures, that is drop attacks. Child will be having a drop of, see, this is a drop attack. Another type of generalized, which is called atonic seizures. Again, this helmets are advised for these kids with atonic seizure because the possibility to have a head injury is very much, because this type of seizure won't be having a pre-seizure phase. Parents won't be knowing, or even the child won't be knowing that I am going to have a seizure. So sudden fall is usually associated with the head injury. So the seizure helmet is usually advised for such kids. Then comes the myoclonic seizures. Myoclonic seizures are usually jerks, myoclonic jerks, as seen in this video. Patient is having a jerks of the muscles. Another may be having a myoclonic attack. See, this is the myoclonus. Another type is tonic seizure. This classification is very important while managing the seizures, and increasing the gravity of seizure means the disease is worsening. A seizure shifting from absent seizure to another type is it should be interpreted as difference in the area involved and also worsening in seizure. This is tonic seizure. Actually, tone of the body is increased for a particular time during the seizure attack. There is no shake, nothing over there, no convulsion. It's just a tone of the body is being increased. Then comes generalized tonic-clonic seizures, or GTCS. GTCS is usually that adulthood seizure. It doesn't usually happen in pediatric age group younger than 8 years. It usually happens in older kids. So this GTCS have a four-phased seizure. Actually, four phases are there. It does have a mandatory pre-seizure phase. Baby will be knowing that I am going to have a seizure attack. That's a pre-seizure phase. A tonic phase will be the, as I demonstrated earlier, there is a bit increased tone of the body. So the muscle contraction will cause passage of urine, bowel, bladder, everything. So it is during the tonic phase that tongue injuries and all happens, that because of the tonic bite and all, which will be followed by a clonic phase. Clonic phase is sudden convulsive attacks. And then after the convulsive attack, when the seizure gets settled over there will be a post-seizure phase as well. Baby will be unconscious during the post-seizure phase, and maybe the child will be having severe headache, drowsiness, or something during that time. So essentially, there are really four phases: pre-seizure phase, a tonic phase, a clonic phase, and a post-seizure phase. This is a tonic-clonic seizure in the convulsive phase. So the advantages of classifying seizure is because every type of seizure gives a clue to the cause of the seizure. Again, for making the prognosis also, we can help. Usually, GTCS gives an indication that usually the pathology is of bit severe type, or an absent seizure gives a clue that it can, for which reasons it can be precipitated. Usually, absent seizures are precipitated with hyperventilation. So, hyperventilation means excess air. So, if a patient comes to you with absent seizure, your advice should be don't travel with sitting on the side of the bus or with the side of the car with windows down. If you are traveling, don't travel in a two-wheeler. If you are traveling in a two-wheeler, make sure that baby is turned to the other side so that wind should not blow directly on the face, because hyperventilation is the main precipitating factor of that seizure. So you should be thorough about the type of the seizure to rule out the precipitating factor. You should be thorough about the type of the seizure for making a prognosis and also for choosing an appropriate treatment. So epilepsy syndromes I'll be skipping off. So and regarding that differential diagnosis, whether to know it is an actual seizure or a pseudo seizure. Usually, pseudo seizures are more common in teenagers. Maybe attention seeking or something. Pseudo seizures are very common in teenage group. And true seizures are usually associated with injuries or tongue bites and all, for which pseudo seizures are not associated with. And the true seizure duration is actually very short, while in the pseudo seizure, they enact it for a longer duration. And post-ictal drowsiness, headache, confusion, everything is seen in true seizure, which is usually absent in a pseudo seizure. And EEG is the best tool to diagnose between a true seizure and a pseudo seizure. But make sure that you are proficient enough to diagnose or interpret an EEG. And if it's doubtful like that, it's better to take a sleep deprivation EEG. And after a seizure attack, soon after a seizure attack, you can screen through an EEG. The EEG is a very cheap investigation and costs only like 1,200 or something. So, or even in government hospitals, it's done at lower rate, like 600 or 700. So, a slowing will be evidently seen if it's a true seizure. So, in the post-ictal phase. So, if you can do an EEG as early as possible, this slowing pattern will be helpful in identifying the true seizure. And also you can see for a serum prolactin level if you are doubtful whether it's a pseudo seizure or not. So you can also go for that. And regarding the Ayurvedic perspective, usually the seizure, as I told earlier, it's an interplay between three factors. That is epileptogenic factor, it's a real villain behind or real brain damage behind. That precipitating factor, which is usually a rasadhatu dushti. That examples were sleep deprivation. Then excess wind blowing or excess stress or mental emotional stresses. Then unventilated stress. Then hormonal imbalances, everything usually so much related with ahara, vihara and all are precipitating. Usually in a paitiga, pasmara and all, spicy foods like pickles or more spicy masala rich food, this will be can act as a precipitator, or even like excess hunger can also act as a precipitator. So usually Nidana, when the Acharya is addressing in Apasmara Chikitsa, Acharya is mainly addressing about that precipitating factors. That is why Ahida Annapana and all are given much importance. It's not that Ahida Annapana will cause a brain damage. Ahida Annapana can cause as a precipitating factor for the seizure, for this epilepsy to manifest. But other reasons are Vyati. And especially a Vyati which can cause a brain damage like Balagraha. Purushagrahas are notorious to inflict a brain damage like Skandha, Skandhavasmara, Naigamesha and all. So any infections which are affecting the brain can act as an epileptogenic factor and a potent reason. Even Visha and Upavisha are stated to be a potent cause for this seizure. Visha in the terms of toxins can act as a trigger or even a cause for seizure. But slow toxin generation.
ಬೆಳಗ್ಗೆನೆ ಮಾಡಿದ್ರೆ ಒಳ್ಳೇದು ವರಮಹಾಲಕ್ಷ್ಮಿನ.
Pardon? Can you please mute the mic? So, Visha and Upavisha, not only toxins, Even internal toxins like amavisha or like in metabolic disorders, when this excess metabolites are getting deposited in the body, it can also act as a trigger for seizures. So that visha could be interpreted in that level as well. Mental agonies we have addressed before. And also the involvement of Sharira and Manasika doshas are dominant. It's not a Sharirika Vyadhi alone and it's not a Manasika Vyadhi alone. It's an interplay between the Sharirika and Manasika doshas. So the classification is something like Vadika, Paitika and Kabaja. Evidently, it's a Sanipadika Roga. But depending upon the dominance of each dosha, we classify it as Vadika, Paitika or a Kabaja. So Vatika Abasmara is usually narrated to be very having a sudden knock. The Chalakva of Vada is even more important over that. And usually the reasons are usually Vada precipitating. Sudden attack, multiple episodes, short duration attacks with no seizure phase. Can you, in this classification, I have summated certain type of seizure which is very short span. Multiple episodes a day with no pre-seizure phase at all. And frothing will be usual presentation. Maybe baby will feel a pain during that seizure or a pain can act as a precipitating cause. Triggered by sudden emotional shock, lack of sleep and all. Nidra Nasha is an evident cause for Vada Dushti. And it can also happen when the baby is immediately awakened from the sleep. And during that this Vadika Abasmara, post-ictal headache will be there. It's not severe Vadika Shirashura. It's not heaviness of the head, it's perfectly headache. And this type of seizure is usually precipitated with a sleep deprivation EEG. You can take an EEG normally when the baby is asleep. Sleep deprivation EEG is actually different from normal EEG. We make this baby restricted, devoid of the sleep for like we advise the baby to have only 3 to 4 hours of sleep during the last day, and baby will be put into stress by depriving the sleep, and then the EEG will be taken. That is sleep deprivation EEG. That's actually a sure shot sign for Vadika Abasmara. And again, hyperventilation is provoking that seizure. So, as I told earlier, absent seizures can also be taught in this line. So, there is usually an underlying Thadukshaya will be there. This type of seizure. Then Paitika Pasmara is usually associated with fever, can be a typical seizure, a typical febrile seizure, like usually associated with Jwara. Maybe a small Jwara like mild pyrexia is triggering a seizure attack. And usually happens in Paitika Prakriti. Increases with photic stimulation. Photic stimulation is a tool used in EEG to diagnose a seizure. During the time of taking EEG, they will be giving stimulation with bright light. So this type of...
എല്ലാവരും 200 രൂപ കൊടുത്തിട്ട് കാണുന്നതാ ക്ലാസ്. അതിന്റെ കോർഡിനേറ്റർ എനിക്ക് മാത്രം അയച്ചാൽ സ്ക്രീനിൽ ഇരുന്ന് കണ്ടു.
Photic stimulation and precipitated by hunger or excessive heat. And as I told earlier, it will be seeing visual aura around every substance during so babies will be narrating that I am seeing something, a bright light around your face, around that ball or anything. So that much aura will be more dominant. This is the easy way to diagnose an Paitika Apasmara, or if you are going for an EEG, this will precipitate with photic stimulation. So you can see a child with Paitika Apasmara. It's a drop attack. So the modern classification, it's an atonic seizure, but it's precipitated by that photic stimulation. Now coming to the Kabajapasmaras. Kabajapasmaras are long duration attacks. It's Chirakali, prolonged seizures and post-ictal period, sleepy duration for more than 3 or 4 hours will be the vomiting will be usually found in post-ictal phase. It's excess salivation which is found. Then, as I told in Vadika Basmara, frothing will be there. But in Kapacha Basmara, it's actually saliva drooling out like anything. Prasega will be there. Frequency is very less. It can happen once in 6 months or like that. But the duration of every attack, if one seizure happens, it will be like 20 minutes, 30 minutes or so. The duration is more, but the frequency is less. Usually it's precipitated with day sleep. Babies happen to have a day sleep or a high quantity of food, Agni-mandya, then the chance of precipitating this is there. So it's not a direct class. This Ayurvedic classification is not a direct equivalent to the modern classification. Even all this modern classification can be included under this. But we need to see it in a dosha perspective, which dosha is more dominant in the type of apasmara. So in an Ayurvedic platform, before managing that epilepsy, we need to see that precipitating cause should be managed first than the epileptogenic cause. So the precipitating cause is something linked with Rasadhatu. So Agni need to be corrected first. So there is a defective digestion and metabolism happening in each apasmara cases. So even though baby won't be complaining about indigestion, they are not that well versed to complain that I am having bloated abdomen or I am having indigestion or anything. It's a defective digestion you should have to assume and give a digestive corrective. For which digestive corrective to give is depending upon the dosha of koshta. See the tongue, if it's coated, it's more kabaja, you can give ashtachurna or something like that mixed with ginger juice. Or you can go for Vaishwana or something like that. Or Panchakola Churna can be a better option. If it's Paitiga Koshta, usually many of these kids with epilepsy do have a Paitiga Koshta. It's not only due to epilepsy, maybe these kids are having anti-epileptic drugs. So the chance of drugs to increase that Paitiga Bhava in Koshta is more. Many of the anti-epileptics acts as a trigger for Paitiga Agni-mandya. So they will be having a reddish magenta tongue with a intolerant towards all spices and all. So Paitiga Agni-mandya should be corrected with Pitta Shamana drugs. Like Guluchi is the best option over there. You can go for Rajanyadi Churna as well. Avipatti Churna can also act as Pitta Shamana in milder doses. So depending upon that Agni-mandya, you can correct it accordingly. So due to this Agni-mandya, there is an accumulation of semi-digested food over there in the koshta, which can be considered as ama, having a systemic absorption leading to Thadukada. That's the concept of Abhasmara Samprapti in the classical literature. Anyway, there is an inevitable Agni in each and every case. So even with the correction of Agni, we can see a remarkable improvement in the seizure prevalence. So examine the Koshta and correct the Agni first level. Then give a Thadugada Amapajana drug. Guluchi is the best Amapajana, or you can even go for Vilvadi Guliga or a Dushi Vishari. Or even you can go for a bit more Amapajana drugs like Shadharana and all, and in more Kabaja cases. But your prescription should start from a Deepana Pajana and Thadugada Amapajana. That is enough in the first course of my prescription. Just 1 or 2 drugs to study the Koshta and clear that gut. And ask the patient to have a seizure diary done. That is to write about the frequency of seizure happening every day, or and the seizure diary should note, or ask them to note when the seizure happened, for how many duration, how much time it happened, and they ask them to write about the detail of the seizure or have a video of the seizure when it's coming. So we can comment upon, like, is it increasing, maintaining a status quo, or decreasing. Even they can comment upon very in a clear pattern. So first level is level 1 is correction of Agni and Agni.
Hello?
Correction of Agni, and second level you can proceed to Srodoshodhana. So Srodoshodhana drugs, usually it is better to go with Sneha preparations. Like Hrida will be more apt for the situation because an underlying Pitta is the dominant dosha of that. So Hrida will be a better option for Srodoshodhana. And then you can proceed to, after this second stage, you can proceed for typical dosha shamana procedures, or you can assess which type of apasmara and then manage that apasmara. Then we are targeting at that epileptogenic factor. Till now, we were addressing that precipitating factor alone by Agni correction and giving a Srodoshodhana. Then, in the third phase of management, we can directly manage that epileptogenic factor. And apart from that, internal medications, Panchakarma therapies will be useful at this stage and this stage alone. So never start a managing the apasmara with the Panchakarma therapies. Correct the Agni, give a Krida as Srodoshodhana, and then if you are confident that the severity is coming down, then you are on the right track. If the severity is not coming down, your track is defective actually. With the first and second phase completed, your severity should come down. Then only you have to proceed to the third phase. So this is the usual management protocol which we follow. We classify the apasmara into 2 actually. As a brain pathology is that we do identify that a Thadukshaya has already happened in the Masulunga. So it should be addressed like a Thadukshaya induced Vada Dushti. So Vada Dushti is inevitable in all types. So we usually classify in Ayurvedic basis, for the clinical purpose, we do usually classify into 2 types, Vata Kapacha and Vata Paitya. Vata Kapacha apasmaras are usually, as I told earlier, the Koshta will be more having Vata cotted tongue, and Agnimandya will be there. So Ashtachurna Shadharana will be the treatment option over there. We can give a Pajana drug which is having a Shodhana property also. Trayandyadi Kashaya is my drug of choice over such conditions. Even Kalyanaka Kashaya can help you a lot. But make sure that when you are prescribing or going for a Kashaya, make sure that you are not using preserved Kashayas. because these preservatives are notorious to precipitate the seizures. So don't use preserved kashaya. Make sure that you are using fresh kashayas, or you can use kashaya churnas and then make it fresh. As the chance of the Adugadama is there, do incorporate Vilvadi Gulika when it is on the Kabavada dominant stage. Or if it's a Pitta dominant stage, instead of Vilvadi, Dushi Vishari will be a better option. Then as a Shamana Kashaya, you can continue with Kalyana Kashaya, which is a good option in Kabavadika types. And then proceed to, so by this time we have completed the stage 1. That is giving a Deepana Pachana and a Shamana Kashaya, we have completed the stage 1. Do check the seizure diary, and if it is seizure is severity is coming down, then make sure that you can ascertain that you are in the right track. If the severity is not coming down, don't proceed into phase 2. Do correct. Maybe your dosha assessment is going on the wrong track. Do correct the drugs in a bit more different pattern and reach a stage where the severity is coming down. Actually, the severity of the seizure and also the frequency should come down. While in the Vata Paitika stage, the clinical diagnosis is baby will be seeing an aura around, and it will be triggered with hunger, triggered with emotional stress. Usually a fever will be associated somewhere in the course of seizures. Then don't go for Ashtachurna or any Tikshna drug. Then Rajanyadi and Avipati will be the drug of option over there. Avipati should be given in milder doses in the initial stage. Rajanyadi Fandakashaya can be given. That's a good option. Then usually I go for Nishundi Shadanga Kashaya, which is my favorite. Nishundi Shadanga means removing the Shundi out of Shadanga and then giving. It is usually given as Toyapaka. Sudarshana Churna actually creates wonders in Vada Paitiga Pasmara. You can use it as Talam, use it as internal medication. Even Sudarshana tablet is also okay. But Churna is a bit more perfect because the binders are actually waved off. And this Kalinga Padolasya Patram Kadgurohini, this is actually told in the Sandada Sadada Jwara of Jwara Chikitsa. Actually, this is a wonderful yoga and give very good result in Paitika Pasmara management. Kalinga Padolasya Patram Kadgurohini. Padawalasya Patram is the best option. Even I have tried with bitter gods. What we call in Malayalam, it's Pavaka. That also gives good results. Kadagurohini is the drug of a choice over there. Even I have tried in patients with, instead of this Kashayam, I have tried single Kadagurohini churna. Kadagurohini as single drug churna. That's also good enough. And there's a Shamana drug, Drakshadi Kashaya is very nice. And even Brahmi Drakshadi Kashaya, which is available in the market, I think it's marketed by AV, Adivadya Nilayam, I think. It's also giving good results. Drakshadi Kashayam is liberally available in the market. This is a phase 1 of Vada Paitiga. Check, at least you need 2 or 3 weeks to complete the first phase in each case. Maybe there is time duration difference between each and every individual case. At least follow this protocol for 2 or 3 weeks. After getting a good result, you can switch over to phase 2, that is Snehana. Vicharana Sneha is well and okay if you are managing it in OP cases. But if you can have an IP admission facility, then you can directly go for Snehapana, Acha Snehapana in Madhyama Matra. Panchagavya Krida is a drug of option in Vata Kabaja types. And you can even think of Panchagavya Krita or Mahapaicharjika Krita. But Panchagavya, even Panchagavya is okay. Panchagavya is a combination even without a single drug in that. It's only cow's urine, dung, then milk, curd, and there is no single drug in that. But the combination is very potent enough to clear that Srodhorodha, increase the nourishment of the dhatus, and clear up the kapha avarana in that. So even Panchagavya without a single drug is very effective in Vata Kaphaja Apasmara. You can potentiate this Panchagavya Krita with anti-epileptic drugs like Villo Panchamula and Villo Panchanga and make it Villo Panchanga Krita, then which is much more effective. Mahapaishajika is another yoga which is, I think it's not freely available outside. In Kerala, it is marketed by Aushadhi. It's also a very promising drug in Vata Kaphaja Apasmara. Then coming to Vata Paittika Apasmara, Kushmanda Swarasa Krita is a single drug of option over that. It's extremely palatable. It's only 2 drugs over the Kushmanda Swarasa and HT Churna. And it's highly palatable and it's a sure shot drug. We have conducted a research on that and it's highly effective in management by Paittika Apasmara. The second drug option is Karaskara Krita. Karaskara Krita has been narrated in the context of Vada Shondita, but it's having high potential in managing Apasmara and also cognitive behavioral disorder in pediatrics. Then Tiktaka, as you all are familiar with, is good enough. So with the Snehana, if you can do a Samana Sneha, that is, make sure that you are not creating an Utklesha in the baby. You should do it as Samana Snehabana, that is, you can give it Shamana Shuddvado Ananno, that is, after the digestion of previous day's meal. When the baby is feeling a hunger, you should give the Krita. That is, you can skip the breakfast, and when the baby is feeling hungry to have the breakfast, instead of that breakfast, you can give Krita. That's a time, actual time to do Shamana Snehapana. Then you can do a similar pattern in the evening also if you need. Otherwise, one time Snehapana is also okay. Make sure that you are not creating Ulklesha. If at all you are creating an Ulklesha, you should do a Shodhana. So after completing the second phase, again make sure that seizure severity and intensity is coming down. Then only proceed to the third phase. Third phase is the phase of Panchakarma, pediatric Panchakarma. So of that, Shamana procedures like Kshiradhara, Takradhara are very important. Takradhara is especially very good for Vata Kaphaja varieties, and especially when Takra is processed with Satya Sthavana Gana. It is very good in managing Kaphaja, Vata Kaphaja type. If it's Vata Paittika type, you can manage, you can process the Takra with Pitta Shamana drugs as well. Again, Kshiradhara. Kshiradhara is another procedure which is indicated only for Vata Paittika Apasmara. Don't select it for Vata Kaphaja type, which is notorious to precipitate Vata Kaphaja type. So do Kshiradhara in the second variety alone. After completing that, or judging an Upashya, Anupashya with Takradhara and Kshiradhara, you can go on to Murtha Daila. Murtha Daila is actually Snehana of the Murtha. So Dashapushpadi, Vachaleshanadi, Tribaladi, Nirgundyadi are the drug of options in Vata Kaphaja type. And while Balahadadi, Chandanadi, Kshiravalla, Vatashini, Mahanarayana are the drug of option in Vata Paittika type. Nasya, the drug of option is Varnadik Shira Krita in Kaphaja and Shirabala or Shiraguluchi in the Paittika type. So, as I told earlier, Takradhara is drug of option in Vata Kaphaja type, while Kshiradhara I can think in Vata Paittika. And Shira Upanaha is a typical Sveda done on the head. which can be taught in Vata Kapaja, and Chirolepa, which is usually a Pitta Shamana procedure, can be taught in Vata Paitya. Tala can be taught in Vata Kapaja, that is BMRD, Bela Mustarasana Devataru. That's a wonderful combination told by Arogya Kalpatrima, Bela Mustarasana Devataru. It's very effective in managing that Avarana Vadas, especially in Vata Kapaja type. And the medium of application of this BMRD, Bela Mustarasana Devataru, is Erenda Taila, Stanya, and Sahadevi Swarasa. That medium is very important. Erenda Taila is having very much Vyavai Guna, which is indicated even in conditions of Amatva. It's actually in Erenda Taila Snehana is indicated in Amavata actually. So this Erenda Taila, when mixed with milk and Sahadevi Swarasa, it forms into a colloid, and when mixed with this BMRD powder, it's very effective in managing Vata Kapaja Apasmara. We are planning for a research for this tala this year. And even you can go for simple talas like Rasnadi Churna in Shigra Swarasa, or Krishnadi Guliga and Karpuravalli Swarasa can also be taught for. But the result of Bela Mustarasana Devataru Tala in Apasmara is unmatched actually. In Vata Paitika Apasmara, we can think of talam with Kachuradi with butter, or Panjagadan Churna with ghee and stanya, and even Mamalaki Churna and Bremiswarasa. Make sure that you're having a very So make sure that you are having a clear-cut dosha outlook when you are going for a tala. So after completing this phase of Sakardara, Murtadaila, and Tala, you can go into the stage of Rasayana or Vasti and Rasayana. Dvipanchamuladi is actually clearing more Shodhana, and it's indicated in Vata Kapacha, while Mustadi Rajayapana Vasti is having wonderful results in the management, Vata Paitika. Again, this Rajayapana Vasti actually comes under the Rasayana procedure. Vacha, Tagara, Taila Lashana, everything comes under Rasayana in the Vata Kapacha type. It can give Vacha Churna mixed with Swarna Basma. Even Tagara Churna, Tagara is, you can get it a single drug capsule, can mix with Swarna Basma and can give that way Swarna Prashana with Tagara or Vacha. Taila Lashana is also very nice. Similarly, Eshti Shankapushpi can be given as Eshti Churna mixed with Pushmanda Swarasa as a juice, or even Shankapushpi is very palatable, can give as such mixed with Krida. This is Panchakarma picture of Panchakarma procedures happening. Lepana, Shire Lepa, I think all are familiar with. Nasya. And this Nehana should be given due importance when you are managing a Nabasmara. Because modern science also elaborates that ketogenic diet is having very much importance in managing an epilepsy. Even our department is having a good tie-up with pediatric neurology department of Trivandrum Medical College, and also the pediatric neurology department of Sri Chitra Institute of Medical Science. So what they comment upon our treatment is that, madam, when you start the ghee, I don't know what is happening, it is coming down. So they usually comment without knowing the essence of the dosha dhatu and all. They usually comment that when you started that ghee preparation, seizure is coming. That much evident is the role of Snehapana in seizure management. So don't miss that inclusion of Kridapana in that. This is a research study which is conducted. We are doing research studies in intractable epilepsy for the last, I think, 10, 12 years. So this is just a sketch of the research study in Villa Panchanga Krida conducted at our department. That is Panchagavya Krida processed with Vilva. That is study duration was 2 months. Intervention was given for 2 months and 2-month follow-up. So this is the result. Patients before treatment, after treatment, and after follow-up. So very good results. See the seizure severity. We are giving that phase. This is before treatment assessment, after treatment assessment, and after follow-up. So the seizure severity is actually very much coming under control during that treatment period. And even when we are withdrawing that drug, that severity is not getting worsened. That is the beauty of our management. So here only single drug has been used, only the Krida has been used, but we have completed the Amapachana before well itself, and then the patient intake was, patients were enrolled into the study. So beauty of that medication is that it's very effective in controlling the seizure, and even with the stoppage of that medicine, the seizure is not showing a throwback. That is regarding the management of epilepsy. So if you have any doubts to clear, I am happy.
Thank you, ma'am. Those who have any doubts, you can ask now. You can unmute yourself and ask if you have any doubts, or you can just type in the chat box below. Ma'am, how can we manage the Vegavastha of seizure?
Again, Vegavastha of the seizure depends upon which type of seizure it is. If it's a febrile seizure, doing a talam which will be very effective. And during the Vegavastha management, we usually incorporate marma techniques along with that. And Shipra marma, Angushti Madhyastham, Shipra Maksheba Maranam. This Shipra marma is stimulating the Shipra marma is very useful in managing that Vegavastha. Actually, that Shipra marma is between Angushta Anguli Madhyasam. It's here actually located. And the stimulation of Shipra marma, that's 3-finger stimulation of Shipra marma, is very effective in managing that Vega attack. And if the baby is going into status epilepticus, you can switch over for usually anti-epileptics, which is modern anti-epileptics like midazolam nasal spray will be usually advised if the baby have a chance to have a seizure attack. So it is like Ayurvedic management is not withdrawing that modern anti-epileptics and introducing. It's like incorporating both treatment for the betterment of the child.
And next question is, what is the proportion of Sagara and Vajra in Sivanagar?
Swarna Prashana, what we do here is actually Swarna Bhasma is taken. Swarna Bhasma is taken in 50 mg dose, milligram dose, and it's it is grinded very well with Madhu Krida. Madhu and Krida is taken in the same volume equivalence. That is 1 teaspoon Krida and 1 teaspoon Madhu is taken in equal volume and mixed with Swarna Pasma, that's 50 milligram, and grinded well morning and evening. That's 15-minute grinding in the morning and evening every day. So every third day we add this Vacha Churna. Vacha Churna, a pinch is added in the morning, and every third day we add Vacha Churna, third, fourth and fifth day. So we start grinding the Swarna Pasma Madhu Krida in equal quantity and 50 milligram Krida on day 1 will be grinded 15 minutes in the morning and evening on the first and second day. Third day we add Vacha Churna, that's a pinch. And fourth day again we add Vacha Churna, a pinch. And fifth day we add again 50 milligram Swarna Basma. Then again grind it for 6th and 7th day. In the 8th and 9th day we again add Tagara Churna. Can decide upon the condition which whether to increase the quantity of Vacha or replace it with another yoga also. It's like the grinding of Madhu Krida with Swarna Basma is more important. And the quantity of Vacha or Tagara you can decide upon.
My next question is regarding West syndrome. West syndrome comes in which category?
West syndrome is comes under epileptic encephalopathy. It's a category of epileptic syndromes which I skipped during that presentation because it is a bit deeper subject. It comes under DEE, that is developmental epileptic encephalopathies. This category comprises of seizures or epilepsies which have a negative role on the development of the child. So there will be a developmental regression, and it again comes under epileptic encephalopathy. So there is an encephalopathy in the brain or a brain damage which is causing this type of seizure, West syndrome. And every time when this type of seizure comes, it's again worsening that epilepsy. So it is like a vicious cycle. There is already a brain damage. It may be a child. I can give an example. It can be a child who is born premature, suffering from HIE, hypoxic ischemic encephalopathy and all. So the baby will be having a slow developmental milestones developing. Maybe by the age of 3 or 4 months, baby starts a seizure attack. So already an encephalopathy is which is creating a seizure. But the seizure is so dominant that with every seizure attack, this encephalopathy will be worsening. So we call it as epileptic encephalopathy. Epilepsy is again triggering that encephalopathy. So initially this encephalopathy had caused the seizures, but on the worsening phase, it's again worsening that encephalopathy. So as the brain damage is worsening day by day, it's usually fatal. The fatality is more with West syndrome. So it comes under, again, as the encephalopathy is worsening, the brain damage is more and more.
My next question is regarding developmental delay. What line of management shall we adopt for cases of developmental delay occurring due to seizure disorder?
This is the same question. This is usually in developmental epileptic encephalopathies is developmental regression which happens. So it should be considered as a Vadavyadi. This increasing Thadushaya which is causing this developmental delay. So it should be considered as a Vadavyadi itself. But directly Vadashamana treatment cannot be implemented over there for fear of this Snehasveda triggering that seizures. So first you should manage that seizure and manage it to such a level that the patient is can withstand a minor degrees of Snehasvedas as well. Then you can shift to Vadavyadi Chikitsa.
Ma'am, till what age it is possible to have treatment that gets 100% curability for seizure?
I didn't get the question. Till what age is it possible to have treatment that get 100% curable for epilepsy? It's not depend upon the age alone. It's a type of epilepsy which depends. 100% of cure of epilepsy is possible at any age. It's not the age alone which is the determinant. It's a type of seizure, the severity of brain damage, all determines that. So earlier the age, it is better every time. But even in the early ages, 2 severe types can be given 100% cure. So age determines severity of seizure and the brain damage. 3 are the determinants.
Ma'am, how can we reduce the frequency of febrile seizures?
Febrile seizure. Febrile means it's not linked with febrile seizure. That's what I was speaking about. Reducing the frequency, and that's how we are managing the seizure.
Ma'am, next question: is there any effect in applying Taila during Vegavasana?
Yeah, we are trying now, and research is happening about this Todu Taila and all this external application of Tailas on joints and especially certain marmas during the Vegavastas. We have tried with 2 or 3 Tailas and some are showing promising results, but I am not in a stage to explain how it is acting in the body. Maybe the absorption through these joints or marmas are too fast even during a seizure attack. It is evidently giving promising results. Maybe in a year or 2, I can give you clinical evidence that which drug is applicable in which way. But for sure, the traditional practice of Todudailas in Vegavastha management is nice.
Ma'am, what about Panchakavya Gruda? Like external application.
Krida we have used as Todudaila. It's not that effective.
Okay. Can you elaborate the conditions of seizures where Snehavana can be abused?
Snehavana can be advised after Dipana, Pachana and Shamana, that is after completing the first phase of management. I have divided the seizure management in 3 phases. First phase of Dipana, Pachana and Shamana, second phase of Krutapana and third phase of Panchakarma. So after completion of the first phase, we can go for Krutapana.
Okay, ma'am. We have noticed that children are crying during night, especially the night before their special days like Choru, Nodigato, etc. Is there any scientific reason for this, madam? Whether you have noticed this type of behavior, what is your opinion regarding this?
Sorry, I haven't noticed that. I have noticed that kids having an excessive cry after this special procedures. Maybe I thought after this auspicious functions or some gathering and all, after that day, after that function, they have, I have noticed they are having smile fever or something like that. So it may be that a routine change in that kids which cause this problem, and also the indigestion during, especially during this introduction of solid food, weaning and all. And also even during that Nulikata phase, I have noted that after that procedure, I have noted. Before that, I haven't noticed.
Ma'am, role of Shirolabam and Shirobiji in managing the global development delay cases with seizures.
Sure. Shirolepam and Shiropichu in the management of GDD cases with seizures, but Shiropichu shouldn't be given in early stages. When the case is indicated for Snehana, after completing the Shamana procedure, then only go for Shiropichu. Otherwise, that Snehana itself can act as a triggering factor and precipitate the seizure. So make sure that Thaila selection of Shiropichu is perfect depending upon the dosha. And then only apply. If the baby is due to have receive a Snehana, then only go for a Shiropichu. Otherwise, chances of have precipitating a fever or precipitating the seizure is much more if you introduce Shiropichu in the young early stages. But and also Shirolepa. Shiroleba, make sure that the baby is having more indicated for Shiroleba. Shiroleba indication is only for Vada Paitika Dushti. So if the baby is having a Vada Kapacha type, don't go for Shiroleba. That's the only thing. Just judge the dosha and have a thorough judgment of the dosha, and then you can proceed.
Ma'am, levetiracetam 100 mg syrup is advised in modern medicine. Good to be given in the long run, or is there any Ayurvedic alternative for the immediate effect and preventing onset of seizure?
Levetiracetam is usually given in kids. It's not an alternative for levetiracetam. It's go for the reason behind. That's why I was narrating all through this through this paper. Go for the reason behind that epilepsy. Analyze the defect. Analyze the dosha involvement and manage the epilepsy. So while managing the epilepsy, you will come to such a level that within a period of 2 or 3 weeks that you are noting a evident decrease in the frequency and intensity of seizure. When the intensity and frequency are decreasing, you can again recheck it with the help of an EEG. If the EEG is also showing a marked reduction in the frequency, you can slowly taper the dose of levetiracetam and slowly wean it off. It's not, shouldn't call it as an alternative. We are managing the pathology and reaching to such a level that there is no that much need of that much dose of anti-epileptics. That's how it acts.
Ma'am, can you please tell about Lennox-Gastaut syndrome and its possible treatment?
LGS or Lennox-Gastaut is again comes under this same epileptic syndromes. As I told earlier, it's again comes under intractable epilepsies. DEE, again, developmental regression will be the atypical hypserthymic pattern will be there over that seizure, and different types of seizures will be there. Maybe this baby will be having an atonic attack and a myoclonic jerks. 2 or 3 types of seizure will be coming intermixed. And also a developmental regression will be happening in the baby. So make sure, usually they will be having, in spite of 2 or 3 anti-epileptics, they will be having, still they will be having. Am I audible? So in spite of anti-epileptics, they are still they will be having seizure attack. So the treatment phase is similar to Vata Kapacha Apasmara actually. Though Paitika involvement is there, but still it's dominantly on Vata Kapacha Apasmara pattern. Do follow that pattern, you can manage it.
Ma'am, one more question regarding Vityasa Chikitsa. Is there any relevance of doing Dukshana and Snehana alternatively in the seizure management?
I didn't get the question.
Is there any relevance of doing Vityasa Chikitsa, Dukshana and Snehana in alternatives?
I have seen many doing such procedures, but when compared to the standard management protocol, I didn't find that equivalent, or I didn't find it that more effective than the standard management protocol. I have tried with that, but I think this stage phase of management is more effective than that.
Okay. Role of Vasti in seizure disorder.
Sure, that's what we discussed. That is Dipanchamuladi Vasti, or it's not a single Vasti in seizure management. Depending upon the dosha involvement, you can give a wide selection of Vastis. But usually for Vata Kapacha Apasmara, Dipanchamuladi Vasti is more effective. When it's in metabolic syndromes, even Vaitarana Vasti can do wonders. But if you are a beginner in seizure management, best one to try will be Mustadi Rajayapanavasti. You can even alter that Mustadi Kashayam with Kalyana Kashayam and try for that Vasti. It's also good enough. But if you are an expert in that Vasti, like different types of Vasti, then well and good. Otherwise, if you are a beginner, do start with Mustadi Rajayapana.
Ma'am, Rubinstein-Taibi syndrome, Ayurvedic management available if yes, please elaborate.
Rubinstein-Taibi is not coming under this category. It's not a seizure disorder alone. So its management is different actually.
Okay, ma'am. Unnoticed seizures cries. Unnoticed seizures cries in early childhood can affect behavior in later.
Pardon? Can you clear the question once more?
Maybe it is regarding unnoticed seizures. Seizures cries in early childhood can affect behaviors in later. Maybe seizure disorders may affect behavior like that.
Can you explain that? Is it really a seizure or just a cry?
Maybe cry related like Dr. Lubina, can you please explain?
If it's a seizure, depending upon the focus of the seizure, it can affect the behavior in later life. If the focus is not linked with the behavior area, there is no chance to have a behavior involvement. Cry is entirely different from seizure.
Okay. The next question, management of seizures in cerebral palsy.
Cerebral palsy is usually having a seizure association because it's again a brain defect which is causing cerebral palsy. So CP kids are usually having more tendency to have a seizure. The management pattern is similar. So if the seizure is more dominant, you have to decide which one is more dominant. If the seizure is more dominant, do manage the seizure first and then the cerebral palsy. The treatment gets complicated if the child is having a Paitika Apasmara and the cerebral palsy is somewhat on the Vata Kapaja line. Then only the treatment contradiction happens. Otherwise, it will be usually the kids will be having a Kapaja Apasmara and the disease is also Vata Kapaja, then no issues. Both the management pattern goes hand in hand. Can do it parallelly. But make sure that dosha association in apasmara is of which dosha. So if it is apasmara is more dominant, you go for that management. And whenever you are incorporating Sveda for cerebral palsy, make sure that you are giving a Pitta Shamanatala. That's the only precaution you need to take.
If allopathic medicine is if the child is taking allopathic medicine, what will be the gap between Ayurvedic and allopathic medicines? And if the symptoms reduces, whether we can taper the dose of allopathic medicine?
Usually I maintain a gap of 1 hour between modern anti-epileptics and our medications because after finishing off the drug gut absorption of that modern anti-epileptics, I do introduce our medication because our medications like ghee and kashaya has a tendency to increase or hinder the drug absorption of this modern anti-epileptics. So I usually ask them to give that anti-epileptics in the early morning and then we proceed with our medication after a period of 1 hour. So maintaining a seizure diary and ensuring that seizure severity, reduction in seizure severity and intensity is much important. But as I said earlier, apart from the clinical manifestations, do ensure or recheck, have a recheck EEG and make sure that the electrical activity is actually coming down or not. Then you can, if it's again coming down, then you can be very confident enough and can reduce, slowly taper that AED, one at a time. Or it can have a, what I do usually is that I give a referral letter to that pediatric neurologist and with the TEG, and I ask the patient to contact the pediatric neurologist whom they are consulting, and so that we have a mutual respect between both systems. So when the clinical manifestation and EEG is coming down, they are happy to take for the medicines. So that is my style. I don't usually taper the medicines by my own. It's not that I don't know how to taper, but it's a mutual respect. They have given their medications, and if it's having improving, they should also know that they are improving with Ayurvedic medication. Then let them taper. That's a respect we should provide.
Thank you, madam. Is there any other question? Now, I think we have answered all the questions. I think we can conclude now.
Okay, shall I wind up?
Yes, ma'am. Just want to tell you, thank you, ma'am, for delivering such an insightful and engaging session today. Actually, we had a low number of participants in the beginning of the class. That may be quite disappointing for you, too, ma'am. Sorry for that. Actually, we had a registration of 50 participants, but maybe because of some timing issues or something, and we didn't know what happened. But the class was highly engaging and highly informative, and participants had a lot of questions, and you all answered every questions, and you answered all the questions. So your contributions have laid a strong foundation for our future discussions, and we are confident that your insight will continue to resonate with those who participated. We sincerely appreciate your time and effort, ma'am. We are looking forward to collaborate with you in future also, ma'am. And sorry for the less number of participants in the beginning.
Okay,
Thanks,
thank you.
Thank you.
Good night.
Thank you. Good night.